Well, we're on here, but nobody's on here yet. or PCMH.
So did I. Actually, I thought we were doing both,
It may be both.
which, as far as I'm concerned, the ADHD is a waste of time. But I'll play for a year.
Definitely not putting as much effort into it as I like.
Well, if the doctor's not doing it, other doctors not doing it, I know it's not going to stick around.
Yeah. I mean, I'll do it right, but. What did you bring a sandwich for?
Because I'm not going to be able to go to lunch.
Well, I mean, you didn't know we were having lunch. Well, we may not be having lunch.
I don't know. So my dog. You're on mute.
I'll mute it.
Hi, this is Kristen. We're just holding until the webinar starts, and I'm going to wait another couple minutes until everyone's on the line.
Hey everybody, it's Dennis Quo. Who else? It's Kristen. Are you on? Is everyone there?
Yes, hi. I just let them know that I was waiting another couple minutes to see if a few more people were about to join.
Hello, this is Dr. Jensen.
Hi, Dr. Jensen.
How y'all doing?
Good, how are you?
Good, thanks. Is that Kristen?
It is. And we're about to start, and I'm just waiting a couple minutes to see if anyone else will be joining us. And Dr. Quo, you can let me know if we should start and if you'd like me to go over the first few slides or if you'd prefer to do that.
If you can do that first few slides, I think that would be fine, and then we can take it from there.
Sure.
Thanks.
Dennis, how you doing?
I'm good. And yourself?
Good. Say, I want to chat with you, if I could, briefly after the call. Do you have some time a little later in the day? I want to talk about patient-centered medical home issues and get your input and advice.
I think between 2 and 3 I've got some time. You want to give me a call then?
Sure. Between 2 and 3?
Yeah.
Great. Thanks, Jeff. Dennis.
Okay.
We have about 5 of our 9 clinics on right now.
Kristen, if I go into WebEx, how do I get in without signing up for WebEx? Or do I have to do that?
If it If you click on that green join button and it says you need to download something to start the meeting, then that's what I have to do almost every time. Just click on the thing that says start application, I think.
Okay.
So I'm just, you probably can't see the screen right now.
I see it. There's the green join
Oh,
button.
okay, good.
Thank you.
So we have 6 of our 9 clinics on right now. So let me know if you think we should just go ahead. Okay, it's 5 after the hour. Dr. Kuo, should I just go ahead and start?
Let's do it.
Okay, great. Well, thank you, everyone, and welcome to our first Arkansas CQN ADHD monthly practice call. Our agenda will be a quick roll call, report on PSAs, a bit of data review, some Me-Health questions, clinical questions, reminders and announcements, and if we have time, presentation on reliable systems, although if we run out of time, we might switch that to the PCMH webinar, which is immediately following this webinar. So for roll call, I can actually see, and it looks like everyone can see on my participants list, that we have Mercy Pediatrics and Sparks and Central Arkansas Pediatric Partners, and I can see APC, and of course, Dr. Kuo is here for ACH. So I'm actually just wondering if anyone is on from River City Pediatrics?
Yes, we're here.
Wonderful. That's great. Thank you. And quick housekeeping, please mute your phones if you're not speaking, and please don't put your phones on hold because we'll hear your hold music. And please feel free to ask questions and make comments at any time or use the chat box. These slides will be emailed to you right after the webinar, and a recording will be made available for those who were unable to attend, and you can find that on our ARAAP website, and I can send you the link to that as well. So, Dr. Kuo, if you'd like to present, I can switch the slides for you.
Chris, I think if you retain the control, I think that would be fine. So everyone, good afternoon. I hope everyone is doing well with the rain that's, I haven't looked outside in a few minutes and I realized it's rain. It looks like it's raining outside. So I wanted to take some time over the next 45 minutes. What we'll do is first go over some of the PDSA cycles and do a check-in with how folks are doing, and just get an update, and also just some discussion about any challenges or facilitators that we've seen. The next part is that we'll talk about some of the data and data updates, and we've got Ed Wise on the phone from the National Academy. The third is that we want to reserve some time with every webinar to reserve time for Dr. Jensen as our resource to talk about ADHD management questions. So the first slide here reviews very briefly the model for improvement. The model for improvement, as we've discussed, is just a little powerful conceptual tool that talks about how to make a change and get you from here to there. So anytime that you want to change something, you really do you have to ask yourself 3 different questions. The first is that you have to ask yourself, what are we trying to accomplish? The second is, how will we know that a change is an improvement? So you have to be able to measure and determine that you have actually moved the needle from here to there. And the third question, which is your idea, is what change can we make that will result in an improvement? And that's where plan, do, study, act cycles come in. Next slide, Kristen. So what we have asked practices to do is that between learning sessions, we will have a set of goals and that we would like practices to work on. From the end of the learning session, the first learning session, we had set a couple of goals. One of them was for practices to meet and work out the workflows for practices. And we didn't ask folks to come in and share some of their results, but I do think that, in future calls that we will be asking folks to share some of the results so we can, have a good discussion about what we're finding. And the second is to start going through the Me Health portal, and in addition to making sure that folks are signed up, that you're able to get to a point where you can start enrolling kids onto the Me Health portal. So we may find that one of the ground rules that I will put with any discussion is that there is no wrong answer, no wrong actions. There is everything that we talk about is a learning opportunity, whether we construe it as you met your goals or you didn't meet the goals that you set out. And if you didn't meet the goals you set out, as I said, you always look at it as a learning opportunity. So under each practice on the left-hand side, you will see that the question that I'll ask going forward is, what are the goals for the time of this call? The do is going to be what actions have we taken since learning session 1. And so I'll ask for some updates from folks about kind of what things have gone on. The study, which we didn't really ask folks to really do this time, but we'll ask going into the future, is what data did we bring to this call and what does it show? And then the action is what are our goals between now and the next month's call? Okay. Kristen, next slide. Okay. So what I'd like to do is just generate some discussion for the next 5 to 10 minutes or so about plans that you had since the last learning session and your experiences. And I want to just open it up at this point. If there's not a whole lot of discussion, I may start calling on folks. But my question is, how are things going? We've asked folks to do workflow analysis, and we asked folks to look at enrollment, to start enrolling. How are things going?
Hello, this is Joy Hill. Can you hear me?
Yes.
Okay. I think we've had some variable success. We're across 3 clinics, so that's been a little difficult. We got the workflow in, and I think Dr. Youngblood submitted it, but it was a little confusing because he was lead physician and he's not here today. But so at my site, my nurse was putting in, we were starting to enroll patients, my nurse and I, and we got about 5 or 6 enrolled, but they don't show up under my name or her name as our patients. They only show up under all the patients. So if they do turn in forms, I don't get notified.
Okay.
And so we've run into a little bit of a glitch there.
Okay. Kristen, do we have Me Health troubleshooting on the phone today?
Yes, we have a section for that. And actually, I think for this section, we were wanting people to just go over how their first PDA went, what their plan was, and what they did, what's on the screen, asking questions about their PDSA.
Yeah. Okay. So assuming that like a PDSA would be to look at your workflow, what are the things that, are you able to share things that you've learned from your first workflow analysis? Joy, are you still there?
Yeah, well,
okay.
our initial workflow was just to try and get all the participating and supporting docs signed up for Me Health. I'm not sure at the other clinic, Meredith might know better, whether they were able to finish getting Dr. Dyer and Dr. J. Morell enrolled on that and how that was going. And then at my clinic, we were able to get everybody signed up and start enrolling, but we did have that problem with not being able to tell whose patients were whose.
Okay. So really, like a PDSA cycle, you said there was a PDSA cycle that was submitted?
Dr. Youngblood had started filling one out, and I thought he had submitted that with the workflow,
okay.
but I don't know since he's not here today. He sent me an email saying what the PDSA was and what the workflow was that he had sent to Kristen. So I tried to send that back to you guys, but I don't know if it got completed. Okay.
We'll follow up on that. Kristen, can you be able to follow up on that?
Sure. I'll definitely follow up.
Okay, great. Joy, thanks so much. Other folks share about your workflow analysis and your PDSA cycles? Kind of your experience so far?
Well, Dr. Scher is here too. We've been implementing the workflow that apparently you don't have a copy of. And our PDSAs we've been doing there at Highway 102 as well, making sure Dr. Dyer does have an account with MeHealth and is working through the training. Dr. Demerel, last she had checked, still had yet to receive the activation email from MeHealth. Okay. So it sounds like we still have some of the operation issues we need to work out to get folks, to get MeHealth working. Right. Okay. Now that's good to know. I think that's what we need to follow up. We'll follow up on that. And then I'm pretty sure that I faxed our QI consent form to you guys, but I guess you guys didn't get it as well. That was. No, we have your MOC form. Okay. Okay. Great. Okay. We were looking for the PDSA, the copy of the PDSA that you put on the PDSA worksheet, but we do have the other parts of your homework. Gotcha. Okay.
Okay. You need my MOC form too, or was it just one for the clinic? You know, Allie is on here. I believe we need yours, but she can probably clarify that.
Since you guys, hi everybody, this is Allie. You guys, everyone speaking is from Mercy Clinics, correct? Correct. So we decided that since you guys all follow the same workflow, we just need one homework assignment from your entire team. So right. The one MOC form is fine, one PDSA worksheet is fine, and then one assessment and treatment flow is fine. So I do have your treatment flow, but it didn't include the assessment flow in there, so I just need that one for homework. Okay.
And what about the order for the booklet? Were we doing one of those for all the clinics, or we were doing that separate?
I have all of your guys' orders separately. I had sent one a while ago, and the other two went out earlier this week, so you should be getting them at all the clinics soon. But I think they actually, the form had me sending it to just one, so you guys can distribute them across. But you guys got 3 orders of booklets since you have 3 sites. We have the booklets at the 102 location, so I'm at Lowell today. So.
Oh, okay. Okay, so I need to get some from you, James?
There are definitely some at the 102 locations, but I believe she's, like she just said, she's sending them to each location.
They're all going to one location.
Okay, they're all going to go.
The same address. Yeah, so I think you should be getting another order. That's enough for 2 more clinics at that same location. That was the address I had. Okay, perfect.
Folks, in the interest of time and making sure that we have some time for Ed Wise and Dr. Jensen, what I'm going to what we'll do as a chapter is we're going to follow up with all of the practices to make sure that I think that we're still at a point where we need to figure out some of the operations. So one is that we'll make sure that that the MeHealth enrollment is taken care of, and 2 is that that we've gotten the communication down so we can get your PDSA cycles worksheets reviewed, and I'll be taking a look at them, and we'll either follow up with you personally, or we'll also ask some folks to talk about their cycles on the next call. if there's no other questions, immediate questions, what I suggest we do is I'd like to turn the time over to Ed, and we'll follow up with folks about the PDSA cycles and other administrative needs separately. So thanks for your feedback to this point. And Ed, are you there?
Might be on mute.
Okay.
Hold on, let's see. You on mute, Ed?
It says he's muted on the interface. I don't know if that's a self-mute or if Kristen, if you're able to unmute him.
I'm trying to unmute him. Oh, wait, yeah. It's not unmuting him on my side, so it might be a self-mute. Allie, is Ed there with you guys?
He actually works from home on Tuesdays, so usually I could just look over my cube wall and see what he was doing, but he's working from home. I just Skyped him, though, to see what if he's on the line or not. So he might be having connectivity issues because it looks like my Skype chat's not going through right now to him either.
Well, I can keep going and we can come back to Ed. Does that sound good?
Yeah, he just texted me and he said he lost internet, so that's the problem. So why don't we just come back?
Sure.
Okay. I'll tell you what, let's go ahead and move on to the clinical questions. One thing I'm thinking is I want to reserve some time if folks have specific clinical questions for Dr. Jensen. Another thing that we can do in the future is send your clinical questions ahead of time, and if we can discuss, so we have some topics to discuss. So my first question is, do folks have things that we want to raise with Dr. Jensen?
It sure is quiet.
Well, Dr. Jensen, do you have any questions for the group?
Well, yeah, one thing I may comment on, and maybe it'll stimulate a little discussion. You know, I did an ADHD collaborative, the very first one done by the Academy and NICHQ, the National Institute for Healthcare Improvement, and Children's Healthcare Quality, I guess it is, with Mark Woolreich, who was at Vanderbilt at the time, and now he's at Oklahoma. And one of the things that we noticed was that people were able to really begin using the rating scales, just as you're able to do now with the portal. Of course, you have all the automated benefits of the portal. But the thing we found was people often struggled, and we found it a challenge to really help the docs and the prescribers adjust the medicine. And so, and what we've seen generally is people tend to use, you know, they'll look at the rating scales, but they won't use the rating scales just like you might use a hemoglobin A1C, really to look for a critical threshold of where you need to get the symptoms down to. On the Vanderbilt, about an average of scores of 1 on the first 18 items, and even on the ODD items as well. And so one thing I would just encourage you to do is, as you use the portal for your initial assessments and then to track as you follow up, keep a good eye on how much treatment response you want. And often we find that 25% is not really sufficient to really help a child get maximal outcomes. And so you really want to shoot for getting rid of any 2s and 3s, always or very often, and get down to the sometimes level for most of the symptoms. So that's just a thought, and that may be a challenge sometimes if we're a little leery of the medications or we're worried about, you know, always balancing side effects. But let me just throw that out there as a really, really good practice. And what we know from the data is your kids will really have the best outcomes if you get them to that level.
Great, Peter. Thanks. Thanks for that nugget of information.
I have a question.
Go ahead.
I have a question. This is Dr. Ibrahim, and I have a question about kiddos on stimulant medications who may develop motor or vocal tics. What is your, I guess, your treatment approach on? Do you discontinue the stimulant? Do you just continue it, or?
Yeah, great question. Well, first of all, we know that kids with ADHD, about 50% have tics. Sometimes you may not notice because they're subtle. And so what we've learned over, now a couple of decades, the relationship between the medicines and tics is kind of variable. So, for example, you might raise a medicine and the tics go away again. You may have it on a lower dose, but not on a higher dose. And so it really depends if the tic is really bothersome to the child or the parent. And so we don't, the data indicates that stimulants don't cause tics. They kind of make them more apparent. And so if a child or a parent is bothered by the tic, you might play with the dose a bit. You may have to consider switching to another stimulant. So for example, you might find a child tics on, say, Focalin or something like that, but not on Concerta, even though it's the same molecule, because sometimes it's related to how fast the medicine is released in the bloodstream. So generally the strategy is, if it's not severe and not bothersome, you can ignore it. If it is bothersome to all concerned, you can play with the dose, switch to a different formulation of the same medication or molecule, like methylphenidate, or switch to the other stimulant you haven't tried. Now, there have been lovely studies of kids with severe tics, Tourette's, and ADHD, and what those studies showed you is you got the very best outcomes by using both a stimulant and something like clonidine. And so clonidine is effective in addressing tic-related issues. Clonidine's more effective for the tics, and the stimulant's more effective for the ADHD. And we don't have the same number of studies with 10X or Intuitive, but I suspect it would work the same way. So sometimes you have to add the alpha-2 agonist in to really fully control the tics that might be bothersome or worrisome.
Okay, one more question. Between generic and brand name stimulant, is there a difference? I mean, is there something that you would recommend, like you recommend a brand name versus generic?
Well, it's a great question. When someone develops a generic, they have to only demonstrate that it's got 75% of the bioavailability of the original patented drug. And so it's not uncommon for someone to say, golly, I work great on this medicine, but I switched to this generic or maybe another form of the generic, and it doesn't seem to be working well. And I think we have to be attentive that that is possible, but costs also weigh in as well. And so, but is it possible that someone does better on a brand? Absolutely. Than on a generic. And so, that's just one of the issues you have to struggle with when, say, someone's insurance company limits the use of, say, certain brands over generics.
Thank you.
Yeah.
Peter, thanks so much. Is Ed back on? I thought I heard someone call back in.
Yes, yeah, I'm back on.
Okay. Cool. Ed, I'm going to give you some time to discuss data and get us set up for the next call.
Sounds good. Thanks. So we're having some problems getting the right data from MeHealth for us to create these reports that I'm going to push out once a month. I feel confident that everything will be cleaned up and taken care of before the next round of reporting. So what I wanted to do is just, first of all, look at the reporting format, so what you'll be expecting next month to be receiving from me. And this is going to be, the first page is going to be all the data rolled up on the national level. So it's going to be data from every patient in every chapter that's a part of the project. So as you'll see, there's one run chart for each of the 7 measures, starting with number 1 up in the left-hand corner. That's the percent of patients with Vanderbilt assessments completed within 30 days of initiation. That's the assessment measure, and you can read the rest of them, but these will be the 7 measures that we discussed, or that were discussed on the learning session webinar. Down at the bottom on the right-hand corner, you'll see that this is going to be a count of the patients registered in MeHealth. So this will be the format that the reports will be, that you'll be receiving on a monthly basis from us. If you can go to the next slide, please. You'll also have the same thing, basically, but on the chapter level. You'll also be receiving one on the practice level that looks basically the same. So you can compare your chapter Arkansas to the other chapters that are participating in the project on each of the 7 measures, and then you'll also be able to look at the practice level data for the other practices in your chapter and be able to compare how you're doing with the other practices in your chapter. Next slide, please. So this data is accurate. We do have accurate counts of the number of patients being entered in MeHealth, so I thought that we could at least look at that. And this is just for December and January, so any patients entered in February are not going to be a part of this report at this point. That'll be a part of the March report. And as you can see, you guys are getting going with 26 patients being entered into MeHealth. Quite a few patients were entered by one practice in Georgia, so it's kind of inflating their overall number a little bit. Next slide. And this is a breakdown of those 26 patients entered by the practices in Arkansas. As you can see, it looks like Mercy Lowell has the most at 14, and then Bentonville 2, Arkansas Pediatric Clinic 6, and Pediatric Partners 4. So each month you'll be able to see how many patients are being entered for each practice, as well as those other measures that I showed on the previous report. Next slide. At this point, this is some other data that I know is accurate, and at this point, there's only one practice that really has the relevant data, but this is something that I think we'll want to keep an eye on moving forward. In the numerator column there, you see the number of patients who started a parent assessment. So a parent assessment was sent out for 2 patients, and those 2 had that completed. That is out of 3 patients that had the assessment sent out to them and activated their accounts. So far in Mercy, it looks like Mercy Lowell, 2/3 of the patients, a very small sample size, of course, but 2/3 of those patients have had their patient account activated, and 2 of those have completed the assessment. And then you can see, again, the breakdown of the number of patients registered in each practice. That way you can get an idea of the sample size for each practice. So one thing that stands out for Lowell is they did have the 3 patients where their parents activated their accounts, but that's out of 14 patients that have been added to MeHealth. Okay. And one last note is I would just like to reinforce that you check the data in your dashboard in MeHealth, especially while we have little visibility to the data at the chapter and national level. Please make sure you're checking your data regularly in the MeHealth dashboard. We have a
Ed, thanks for the information and the presentation. Folks have questions for Ed?
Hey, Dennis, this is Chris. Can you hear me?
Yeah.
So one of the things on MeHealth that we noticed is that when we're getting Vanderbilt assessments back, that it doesn't give us any type of alert that they've been completed unless it's the assessment. So the follow-up forms, we're not being alerted to them showing up in MeHealth. Is there a setting that we can set that we get some sort of alert when a parent or teacher completes a Vanderbilt?
Yeah, I actually don't know that question. Ed, do you have the answer?
That is Yeah, I do. Unfortunately, there is not an alert for the follow-up, so you're exactly right. When the assessment is completed by parent and teacher, you will receive an email alert, and you get that little flag at the top of your login screen, but there is not an email sent for completed follow-up assessments. Now, I will say that every chapter someone has asked the same question or suggested that they have a flag for the follow-up emails. I'm going to talk to MeHealth this afternoon, and I'm going to see if that's something they would consider doing, or, you know, what is their rationale for not having the flag for follow-up emails.
Thanks, Ed. Other questions?
Yes, this is Dr. Abraham. I have one more question. When we started the program, I logged in as an administrator, and then later on I added myself as a physician. So on the physician list, or the practice, I guess, practice list, I'm listed twice. So if they enter patients on one name, one of my names, sometime it would show as I'm the primary care doctor, and some of the other, if they enter the patients on my name that is administrative, it will not go as if I'm the primary care doctor. So is it do I have to be listed twice, or can I remove the administrative one?
I'll work with MeHealth to remove the administrator one. Is someone else the administrator at this point at your practice?
No. Would it be like preferred that one of them would be the administrative? Yeah,
we're going to want to have one administrator for your practice. It doesn't necessarily have to be you. You want to give me a name, or would it be better if I follow up offline?
I can give you a name now.
Okay. Who would you like to be set as the administrator?
Ashley Morton.
Okay. Okay, I'll have her made as the administrator. Make sure that any data that's related to your administrator account is tied to your physician account, and then get rid of your administrator account.
All right, thank you.
This is Joy Hill. That might explain my issue that none of my patients show up under my name, because I'm listed as administrator at my building too, so they may be assigned to my administrator account and not my physician account.
I also have the same problem, because reviewing that data, this is Dr. Scher. I know that I have reviewed and spoken with families already about one completed evaluation, new evaluation in MeHealth, but it wasn't included in your data. So I don't know where it's getting lost. It may have been a February as opposed to January data entry information, so it'll be in next month. I'm not sure, but I have a lot of patients that I have personally entered in that are not showing up, and I've got an administrative and a physician account as well.
And can you check on CAPC as well? I can see it on my end, but I don't think that you all have it.
What was that? What for CAP? Is that what you? Okay.
Yes, Central Arkansas Pediatric Clinic.
Okay, and again, that could be part of a couple of things, as Dr. Scher pointed out. He knows at least one of the data points might be from February data, and that's not included in the data we reviewed. Okay. Any other questions?
Ed, thanks so much. I appreciate your time and the questions, and we'll follow up with you about any other questions that'll come up as well.
Great.
Great, thanks. We got about 7 minutes left.
This is on a part that if you did their...
Kristen, go ahead and let's go ahead and finish out the reminders, and I'll present a couple of things of reliability, and then we'll switch over to the next phase of the call.
Okay, great. If you have further V-Health questions, please contact Ed. And if you have not filled out your LS1 evaluation, please do so as soon as you can. There's the link, and I'll send it out again. LS2 is on April 13th or April 20th. It's a webinar, and again, please register for that if you have not. Our LS3 will be on August 5th at the Little Rock Embassy Suites. And our next monthly call was supposed to be on March 22nd, but that's during everyone's spring break. So we're going to move it to the following Tuesday, which is the 29th. And here's who we have who's already registered for LS2. So thank you for doing that. And if you're not on this list, if you could register for one of those 2 dates, that would be wonderful. And Dr. Kuo, do you want to go over a couple of these slides, or should we wait for the...
Let's go, yeah, I'd like to, there's a few take-home points that I wanted to go through on reliability, and we can cover it more in depth in future calls. So folks, I like talking about reliable systems, and this was actually going to be a number of slides that we would have presented in the in-person learning session had we met in person. Since we didn't and didn't have the time, I just like to go through some of these concepts and just for food for thought. So the concept of reliability is that when we're looking at a workflow and we're looking at a reliable process, what you're essentially doing is saying that you want the process to function as you intended it to in the required time that you intended it to. And the extent of failure-free operation over time, you have to think of anything you do in healthcare as a process, and you want it to be reliable so that you know it's actually going to happen. So just very simple example is that if you give out a Vanderbilt form, you want to make sure that you actually get the results back, because that's going to help you understand what's going on with the child. Kristen, let's go ahead with the next.
I have a quick question about the reliability thing. We did notice that on the portal, there's like some forms that you can print out for the parents to sign for like authorization of release of information related to that diagnosis. Do we have to get that approved by our current clinic to be able to use these?
You mean from a MeHealth standpoint?
Yes.
Ed, can you answer that question? Are you still there?
Yeah, that is for if you are sharing the record with another physician or provider. If you look down at the left hand of a patient record, it'll show you, it'll give you the opportunity to share that record with another provider, and that's what those forms are related to. It's not for entering the patient.
So we don't have to get those signed just routinely on every patient then?
No.
Okay.
Thank you.
Great, thanks. Okay, let's go to the slide. Let's go to, see, not this slide, next slide, next slide. Okay, next slide. Okay. So when we talk about a reliable system in industry, they talk about the failure rate. And the failure rate means how often does something happen that you don't intend it to be. So if you try to draw a circle 100 times, and for some reason, 1 out of every 100 times, you draw a square. For whatever reason, you draw a square instead of a circle. Your failure rate for drawing a circle is 1 out of 100. And we look at reliable concepts as how often you have a failure. And if it's 1 in 100, then we say that you operate at a level 2 or 10 to the negative 2 reliability. So you need to have you know, anywhere between about 1 out of 10 failures to be considered level 1, 1 out of 100 to be level 2, 1 out of 1,000 to have a level 3 reliable system. And you think about how many times that you prescribe something and think about the, you know, whether a child actually gets that intended treatment, such as if you prescribe an antibiotic, how many kids out of 100 will actually get the full 10 days of antibiotics. I think it illustrates that in healthcare that our system isn't as reliable as we would expect. Next slide. And I think a couple of comparisons. Next slide, please. And so some comparisons are interesting in this chart. This is a fairly, we like this chart because it shows you where we are compared to a lot of other processes that are out there. So if you look at 10 to the -2 or a level 2 system, again, think about the number of times that you actually give out an antibiotic for an ear infection and how often the child completes that course of antibiotics. And it's probably somewhere close to the 10 to the -1. But if you look at other industries, cardiac surgery is about level 3, road safety and chemical industry is around level 4, blood transfusion and anesthesia is actually around level 5 safety. So their failure rates are very, very small. And you have to think about, when you give a blood transfusion, think about all the checklists and think about the protocols that you have in order to safely give a blood transfusion. And that's why the failure rate is so small. Next slide. So we want to talk, the next 3 slides, we'll talk about some of the things that you have to implement in order to get to level 1, level 2, and level 3. Level 1 is basically you get reminders and you become aware of what's going on and you work harder. Level 2, next slide, please. Next slide. Okay, let's go to level 2, when you get to a more reliable process, and again, your failure rate is about 1 in 100, is that all of a sudden you're really looking at real-time identification of failures, checklists, redundancy, and standardizations. Next slide, Kristen. And so under a standardized process, you want to look at your roles and your care of contact and use your MeHealth prompts when it's time to use a Vanderbilt screening. And so this, for example, is where you look at your workflow and think about where you can standardize the process and make sure that something happens when you expect it to do. Next slide. Additional examples include 2 people verifying that people have been notified for a follow-up visit, a diagnosis of follow-up patient conversation checklists, and daily review of no-shows and plans for follow-up. Okay. We'll go through level 3 at a different conversation. So I want to thank folks for being on call for the ADHD portion. And, well, let's go ahead and cover the PCMH part of the webinar. We've got a few things that we want to discuss. So we're going to switch into PCMH. Kristen, go ahead to the PCMH update slides. Okay. So I want to remind folks that under PCMH, there's a number of updates that we have that are coming up. The first is that the high priority beneficiaries are coming into the AHIN portal on March 9th, or it's projected to be March 9th. So what we are encouraging folks to do with the HPB lists is that you need to be looking at what your HPB lists are going to look like, because by the time that you've got the actual list dumped in the AHIN portal for Medicaid, we're going to have 3 weeks to be able to certify the HPBs. So I have a question for the group, for a PCMH question for the group. What is your expectation for being able to do the HPB selections? Are folks working on them right now, or or are folks waiting for the AHIN data to be put in? This being the 3rd year that we have the AHIN, that we've been going through this process.
Dr. Clark, I have a question. What does HPP stand for?
The high priority beneficiaries.
All right, thanks.
Sure.
Dennis, this is Cheryl Arnold.
Hey, Cheryl.
We're already working on ours. We're going ahead and reclassifying by our identifier the ones from 2015 that we want forward. And then throughout the year, new Medicaid patients that were not on our HPB list for last year that may be a newly diagnosed asthmatic or ADHD or other chronic condition. The providers send messages to our patient-centered medical home coordinator throughout the year. So we have those identified to tag in our system so that then when the portal generates our list, we can at least have a starting point and go ahead and classify the ones we have tagged in our system if they are, in fact, still on our panel list.
Okay.
So we're hoping to have, we'll have to have around 720 high-priority beneficiaries this year, we're anticipating, and we're hoping that we have between 525 and 600 that we can carry forward.
Okay, great. That's great. That's great feedback. And what that's what I'm encouraging. What I would encourage folks to do is get a head start. What you're describing is a process that's been going on pretty much all year. You know, like folks have been designated and tagged pretty much continuously.
Yeah.
So yeah. So I think that what we're expected to be doing at this point is have those lists pretty much prepared so that when you have that small, that window to designate your patients, that you go ahead and do so, that you use an internal list and you match it up with, and you go ahead and designate your kids during that window when the HPBs are downloaded. So I appreciate that feedback, and that's exactly what I would recommend folks do. And if folks are having trouble with that, let us know. March 16th, so those per member per month payments, the support payments are scheduled to come in on March 16th, so they're a little bit delayed compared to the previous year. But the following payment, the second quarter payment is supposed to be coming in May, so that should revert back to a normal schedule. The March 31st is the deadline for the attestations, and the attestations, there's your clinical quality metric data and your high priority beneficiary attestations for who's going to be on your HPV list for the rest of the year. The other question I have for folks is whether folks have any specific experiences or if things have gone relatively smoothly, if you already had the 24-month and care plan validation audits going on. We, at Children's, we have our schedule for Friday, so we haven't gone through it yet. You know, you should be scheduling about a half hour to an hour and a half, so make sure you schedule plenty of time. And what we are also recommending is that any additional documentation you have for data service for a care plan, I think will be helpful. As we are trying to make sure that our colleagues who are doing the audit have sufficient information to be able to assess the work that you all have done. Any comments or feedback on the audit so far? Has anyone gone through the audit that, you know, anything that we need to know to make a successful audit? Have folks been contacted for the audits?
Ours is scheduled for Monday, Dennis.
I'm sorry?
Ours is scheduled for Monday.
Monday, okay, so they're all coming up. Anyone else? Yeah, if folks have been getting their audit scheduled or if folks not heard from AFMC yet?
Dennis, this is Roger Williams with River City Pediatrics, Dr. Laura Williams. Ours was done about 2 weeks ago, I guess it was. The care plan audit, we submitted ours electronically like they asked. We have not received any word back on, you know, how we did. So I don't know what the timeline is for them getting the results back to us. But we've had both our 24-month and care plan audits done, and no problems as far as we know.
So it sounds like it went did it go relatively smoothly from your end? Any bits of advice or experiences to share?
No, I mean, we used their secure portal, their secure email that they suggested, and it went through just fine. We got a receipt back that they received it, so It's there in the works waiting to be reviewed, I guess.
Okay, great. Any other reactions, thoughts, experiences? Okay.
Dennis,
next slide. Yeah, yes.
I have a question before you go further.
Sure.
Has there been any explanation offered regarding why there's the delay in the first quarter per member per month payment for PCMH?
I actually haven't heard. I actually haven't heard the explanation for why. Kristen or anyone else, are you aware of an explanation?
You know, I don't think that they explained that on our recent meeting, but I know, I'm sorry I always call on you, Rhonda, but if you've heard differently, please let me know.
Yeah, there's a call tomorrow. There's a strategic advisory group called tomorrow. The first I'd heard of that was, I think, at the last SAG call, and I don't think the reason for why it was being delayed came up at that visit.
I would just offer the comment of we're held to all the deadlines and honor them, that they should honor their schedule with us as well.
I hear you.
But I also have a question on, when we received the shared savings money in October, we were told that the approximate 10% that was withheld for balancing and everything at year end would be paid out in January, and we've not heard anything on that either.
Okay. I don't know the exact answer for that. I do know that there is a final payment, or there's an additional payment that should be made in April. So what I will do is April 28th is actually the date that I had heard. Kristen, let's make a note for this. I think that's a question that we need to find out if April 28th is the final date for when those are, because I know there's a payment going out on April 28th. At least that's the date that I have heard. And we can find out let's make sure that we get back specifically with Cheryl about that.
Okay, because that's inconsistent with the information that was sent out in October.
Yeah, no, I think I recognize that. The reconciliation was to make sure that they run the final numbers for the for the payouts, because they're looking at so some of the things I know they were looking at included the with the final run of their numbers, plus also an additional number of clinics that they had that had been that they had calculated for shared savings that they were putting into the mix. And so the last I'd heard about that, where they were still running the numbers and they hadn't calculated the final payouts, and I think the number was supposed to be available. I think they told me they were going to finish that by March. But what that means is that I know the end of April was the date that I had heard. So we'll verify that for you.
Okay, great.
Good. Great questions. Any other questions before we move on? Okay. Next slide. So the attestations, the top 10% are high priority beneficiaries, which we discussed, and also the clinical quality measure data, which, as you know, that are the same as what you would attest to under meaningful use. Next slide, please. And I want to remind folks about the practice support metrics. So there is one practice activity metric, which is the care plans, and the practice support. But the practice support activities are what we need to be attesting to over time. The thing that we want folks to understand and make sure is that for those practices that were in the PCMH program 2 years ago, you'll see that these metrics look the same. And the one that's new is the childhood adult vaccination strategy, but the C through G are the same. We are asked to redo those. Redo those assessments
and documentations. And, you know, this is really to ensure that we're continually looking for opportunities to improve our care. Are there questions or reactions or thoughts about those areas? So again, looking at the 6 months to make sure that you're prepared to do those reassessments. Okay. Next slide, please. So if you look at the 12 months, you can see that there are, again, fairly similar assessments that we'll be asked to reattest. The e-prescribing, the care plans, the EHR, I'm assuming that folks have already implemented into place. The established processes that result in contacts with beneficiaries who have not received preventive care. You know, you're really looking at being able to document the kids who aren't coming in for your, that haven't come in through a regularly scheduled process, such as if you know that 30% of your kids are, for your 3 to 6 year old time frame, are not coming in, had not been in for a health supervision visit for the last 12 months, that you are doing some sort of a reminder recall for those kids. If folks want to share what they're doing on Activity I, you know, we don't have to at this point document what's going on with Activity I until the end of December, but I'm interested in knowing if folks are already doing Activity I and what they're doing. So one example is that what we're doing at Children's is that we're looking at, for kids who, every month, we look at, see if kids who have a birthday on that month, whether they've been in for a regular well child check in the previous 12 months. And what that does is it gives us a list, and we look and see if they have appointments coming up. And if it looks like they have not been in and they don't have an appointment, then that's a flag for us to start making phone calls. Are other folks doing activities around Activity I?
We have our recall process that checks for whether we've coded a checkup visit within the past 12 months and use our texting system to send a text reminder. But then also our patient-centered medical home coordinator, as she is working and tracking as these patients come in and care plans and everything, will send additional notice if they are due for a checkup, so that we're compliant with high priority beneficiaries. Yes.
And are those, is that, they're flagged for to know that it's time to send out a text? Is that an automatic program? Is it something that's built in your EHR? Is it something you do manually? I'd love to hear more about how that process works.
The system that we use is called Vital Interaction, and it interfaces with our EHR, and we'll search on those codes. And so on a daily basis, we actually have the criteria set that we don't contact them until they're over that 12-month mark to like at 13 months, so that if they're scheduled, we're not sending them a text and they're scheduled. But if it's been over a year and they don't have an appointment scheduled, then they just get a text reminder. Since we've gone to the text versus the calls or mail out, we've had a better response. Now, we do send a letter when we're working our high priority beneficiaries.
Okay. That's great. I was going to ask you how the texting was working. It sounds like you've had better successes with it.
Yes, we've had better successes with it on recall and on appointment confirmations. I'm sorry. On appointment confirmations, our no-show rate
Great.
dropped.
Fantastic.
Thanks. Other experiences with activity I? Okay, next slide, please. These are the metrics. These are the shared savings incentive metrics, and those are the targets, and I just want to make sure that folks, again, see these metrics before we go into just like a quick presentation about care teams, just for food for thought. Bear in mind, again, that all of these metrics, the targets are continually reviewed and set partly to move the target a little bit, but partly to be reasonable in helping us achieve the targets. And for example, a number of the ones that have kept moving is the 12 to 21 year of age has moved. The high priority beneficiaries who've seen by any primary care practice in their PCMH at least twice in the past 12 months has moved up to 80%. And so don't be surprised if when you get your reports you do see that the targets have moved. Because the targets will continue to move. One thing that the medical societies have looked at was to make sure that the targets don't move too quickly, so they have to be no higher than the median of where the performance were for the previous year, so that that they're fair to that the targets don't move to a point where none of us can achieve it in a short period of time. Next slide, please. And most of these on the second page are for 18 and over, and so it's unlikely that pediatric practices are going to be looking at these numbers, but metric 15 certainly does apply, and again, that is something that you'll be attesting to, based on your clinical quality metric. Next slide. Any other questions? Okay. I'm going to take about 5 minutes to just go through a couple of team slides, and then I'd like to discuss a little. Then we'll talk a little bit about the. We have the annual meeting for the chapter is coming up in a couple of weeks actually, and we'll give a little bit of information at the end. So I know we talk about team-based care, and I want to just go over some of the importance of team-based care because everything that we're asking to perform in a high-performing system is talking about taking care of populations. And if we talk about populations, we then talk about taking care, having care teams to be able to take care of those populations. And so the definition that we use is, I think one of the best ones comes from the Institute of Medicine, which says that team-based healthcare is the provision of health services to individuals, families, and or the communities by at least 2 health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated high-quality care. Next slide. And the reason teams are important for us to think about is that we look at improving patient outcomes, but I think the other important one is that it makes our practices more efficient when you think of everybody as a team. The reason is that when you're assessing your population, you have to understand the demand for services, but you identify your ideal composition for who does what, and that everyone is able to work at the top of the license and training. It's really about defining roles of what everybody does and thinking about the identity of the team that takes care of the population of kids. Next slide. So care teams are a basic building block of high-performing primary care. And large teams can be difficult because you've got a lot of folks who have to communicate information and coordinate tasks, and if one person is not cooperative, but the entire team can fail. So what we like to think of with teams is that you think about your practice in small teamlets that are responsible for a small panel of patients. That way that you increase your identity of a team for your patients and families, and then they are able to break down an office structure into a smaller number of people that they can identify with. And I know that some folks have talked about that they have broken up their structure of their practice into individual teams that are wrapped around an individual provider, for example, assigning specific office staff to specific providers and vice versa. And I think those are things that we certainly recommend. So the next slide is possible care team domains. You can think of a team as an office visit team, and that could be something that folks have called a microsystem or a pod. And that pod may consist of the practitioner, medical assistant, receptionist, pharmacy, financial, et cetera. Or you can have a care management or a care coordinator team. A care management team is generally someone who is focused within an office setting. And at the last learning session, we had heard about behavioral health teams, for example, but you can think about who is wrapped around the care of a particular patient, including a care manager. Sometimes you might have a coach, social services, or part of the team. And a care coordination team for a patient, you might think of external specialty or other providers that are part of the management, and this may become more important for a child who has multiple specialty needs or medical complexity. And so there is not a single right definition of what a team looks like, but what you do is think about what suits your own health center and your patient population. But the key here is that you've identified your team members for a particular group of kids, and it could be the group of kids that come in that day, that's your office visit team, or it could be a panel of patients, which is your care management team. You could have an asthma team, you can have your ADHD team. It really depends on how you want to set it up, but you really have to think about the roles of the folks that work within those teams. Kristen, go to this slide, the principles of team-based care. Let's go forward to, I'm sorry, let's go back. One more, there you go. Okay, we're going to end in this slide, and I'd like to close the meeting with a discussion about the annual meeting. So when you put together a team, you have to have shared goals, which is that you want to take, what you want to achieve by forming a team. You need to form your roles within the team, have mutual trust between your team members. There has to be effective communication, and you need to have measurable processes and outcomes, which comes right back to the need for workflows and PDSA cycles. But with regards to effective communication and mutual trust, we always talk about team leaders, but we also talk about mutual respect among different team members. And I encourage folks to think about how do you build trust and relationships and communication between your team members. It is easier to do something to build a high-performing care team if you have those shared goals, those clear roles, but you can have regular meetings, you can have ground rules for meetings, and you can have huddles that really build that sense of team. So, for example, a team for a team that based on office visits for a pod, for example, that you have a pre-clinic day huddle that goes over specific patients and visits that you anticipate during that day so that folks are on the same page, including from the front office person all the way to the providers and the person who checks the patient and family out. So with that, I'd like to go to the last slide, which is the Arkansas Chapter Spring Meeting.
if folks haven't seen the invites for this yet, because we have sent out a lot of invites and we've sent this out over, invites and the listserv. The spring meeting is coming up. It's in 2 weeks, and what we have on the a couple of things that I want to mention. The first is that we are hosting 12 p.m. on the 4th a noon conference for the residents at Children's, and we're going to be kicking off a resident mentor program that will match mentors with residents to help really bring folks into the post-residency community. That is going to be at the Crest Boardroom at Children's, and we're real excited about that opportunity. We've got a number of practices who will be presenting at that meeting as well. There is, in 1 to 5, there's still room in the 1 to 5 section. There is going to be a program on the early intervention system and evidence-based interventions for autism spectrum disorder, and that's going to be at the Pleasant Valley Church of Christ out in West Little Rock. There will be a cocktail reception at 6 p.m. at the home of one of our very own members, Dr. Chad Rogers and Mr. Eric McDaniel. So that's going to be at 510 North Palm in Little Rock. And on the 5th of March, there's going to be a dynamic discussion with multiple guest speakers in healthcare payment reform. That includes folks from a number of payer communities, including Medicaid and Blue Cross Blue Shield. We've got folks from Children's. Stacy Zimmerman will be presenting on her practice and her experiences with NCQA and practice transformation. And we'd love to see as many folks turn out as possible. We know that at this point it is hard to rearrange schedules for Friday, but we'd love to see every practice send at least one person for the March 5th meeting in particular. So send us, there is a SurveyMonkey link for the registration for the spring meeting, certainly let us know if you have questions about attendance as well as hotel accommodations. Any final questions since it's 1:15? Okay, so I thank everyone for their attention. Y'all have a great day. Stay dry and warm, and we'll see you next month.
Thank you.
Bye.
So